Awesome. Well, now that we are at the top of the hour, I want to be respectful of everyone's time, so we'll go ahead and kick things off. First of all, thank you all for joining us this evening. My name is Brooke. I'm a speech pathologist here at Tim's Medical, and I am super excited and honored to have Dr. Raquel Garcia with us this evening for our presentation. A couple of housekeeping items before we get started. This webinar is free for all to attend and is eligible for 0.1 ASHA CEUs or 1 PDH. If you'd like ASHA CEUs for attending this presentation, we ask that you stay for the entire 1 hour segment and that you fill out a brief survey within 7 days. I'll put the link to the survey in the chat, and it'll also be sent out to you via Zoom email within 48 hours. Additionally, if you'd like a certificate of completion, we ask that you just send us an email at tims-unit@tims.com. And again, that information will also be put into the chat, and it will be sent out via Zoom email within 48 hours, and then again, 5 days after, just in case you forget. But if you don't receive the email for some reason, just send us an email at tims-unit@tims.com, and I'll send you that survey link as well. And with that, I'm going to hand over the floor to Rocky.
All right, thank you, Brooke. Thank you so much, everyone, tonight for sharing your Wednesday with me. I really appreciate it. And thank you to Tim's Medical for inviting me to geek out with you all, because I'm excited to talk about working with infants who have a cleft palate, cleft lip, or craniofacial difference. So I'm really excited to talk with you all tonight. So my disclosures are here. I am getting an honorarium for this webinar, and then I am very active in other parts of our field. So hopefully I'll see you on a board somewhere or a meeting. And our learning objectives tonight are, I wish I could talk to you for a few hours, but we're really going to try to condense this just to infants. And hopefully we can learn more in the future for older kids. But we're going to talk about cleft and craniofacial differences and how it can impact swallowing physiology. We'll talk about different feeding challenges that we might see in this population, talk about some clinical strategies we can use if we're suspecting some type of dysphagia or feeding difference, and then how can we use different strategies to support development, but also support parent engagement. So just these are concepts most of us know already, but just to kind of put us all on the same playing field, I really want us to just address what we're looking at when we're thinking about swallowing related to infants. So swallowing safety is essentially airway protection and airway defense. So we want to make sure that the child is able to drink liquids from the bottle, drink liquids from the breast, and safely protect their airway to ensure that everything is going into the stomach, going down the esophagus, and they're swallowing well. This is a very coordinated movement, coordinated functions, where it's not just, are they able to close their vocal folds and protect their airway, but they're coordinated movements from their articulators, from their pharynx, their larynx, and their upper esophageal sphincter. And then when we think about swallowing efficiency, this is the second primary goal for swallowing for infants. And this is where we're thinking about when the child is bringing the bolus into their mouth, bringing in the milk into their mouth, are they able to clear it efficiently with minimal effort, with minimal energy expenditure, and are they able to do that over and over and over again in a safe, in an efficient way to clear the oral pharynx and esophagus. So is this something that they're able to do? And is this something that is very pressure generated system? So we need a lot of pressure in the system in order to clear the residue from the mouth, in order to clear the residue from the pharynx and the residue from the esophagus. So it's very critical for this baby to identify if they're able to have an efficient swallow. And then when we're thinking about feeding development, there's different types of goals that we're looking at as well. And it's different than feeding swallowing, but swallowing, we're just looking at two main factors, safety and efficiency. Safety, can they protect their airway? And efficiency, can they clear the pipe, essentially? But feeding development is, we're working with children and families, and we know that feeding is a developmental skill. And that is something that hopefully can start becoming on our developmental scales and other factors like that. And when we first think about goals for feeding development, we should always be thinking about that parent-infant dyad. So the mother, the father, the grandparents, whoever has that meaningful relationship with the baby and is rearing the baby, how can they bond with the baby? How can they co-regulate? And how can they build confidence together during the act of feeding? And that's something that is such a beautiful thing to observe with families, but it's also something that's very challenging and emotional for families when it's not able to be achieved. The next thing for feeding development we should be thinking about is how can we promote and protect brain growth and neurodevelopment. So early feeding experiences are essential for brain growth and neurodevelopment. It helps with brain organization, and we know that adequate nutrition and positive sensory motor experiences help with neural connectivity and help with the child's regulation of the feeding experience. And then we want to really think about something called growth velocity. And growth velocity in infant feeding refers to the rate of change in their measurements over time. So their height, their weight, and also their head circumference. And this is something that sometimes parents get very fixated on because it's a number and they want to make sure that number is moving up. And it's something that physicians focus on, speech pathologists focus on, dietitians focus on, because we want to make sure the baby's growing. And oftentimes this is something that affects parents and triggers parents because it's such an important factor of their baby's development. It's such a strong factor that we look for. And then we really want to make sure that this beautiful human that just got, born and birthed, that they're developing experiences from the day they're delivered that are positive from a motoric perspective and from a sensory perspective. And we know that feeding is an experience dependent skill. So meaning that if you're not getting that experience, you're not going to get the skill to build the next layer of feeding that you need or for swallowing that you need. And if you don't have a good experience, you're not going to be able to get that skill reinforced in a positive way for you to want to do it again. So this is where the child starts to trust the breastfeeding. They start to trust the bottle feeding because they have the experience, they enjoyed it, and they want to do it again. But if they had an experience that wasn't good because maybe they were being fed when they weren't ready, maybe they were really medically sick, or maybe they just weren't using the right bottle, maybe the nipple was too fast, then they start not trusting the feeding experience, they're scared to feed, and then it's a cycle of where the child becomes unregulated when they feed and they don't want that learning experience anymore. It gets disrupted. And when we start thinking about the babies that we're working with, we want to really think about their anatomical structures that are needed for feeding. So we know that the lips, which we have an upper lip and a lower lip, their primary function is going to be to create a seal around the nipple. And that seal is going to help maintain intraoral pressure and prevent any anterior leak from the milk. So that could mean the seal be going around the breast tissue, the seal going around the bottle, the plastics of the bottle. Next, we have the mandible, which is your lower jaw. And the mandible really provides stability for suck rhythm. And that mandible is really going to allow for small vertical movements that support the compression factor of the bottle. The mandible also anchors tongue movement. So we want to really look at what the mandible is doing so we can really identify if the tongue movement is accurate or not. Movement, and this is going to be intrinsic and extrinsic tongue muscles. So intrinsic muscles, always think of like those fine motor movements of the tongue that are smaller that the tongue has to do. And then the extrinsic tongue muscles are going to be the gross motor, those big motor movements that the tongue has to do to eat and deliver the milk in the mouth. So the primary driver of milk expression is compression. That's one of the primary drivers, and your tongue is part of that. The tongue is the biggest organ, is one of the biggest organs. I am obsessed with the tongue. I always think about the tongue and think of all these new things I want to learn about the tongue. And it really is a pressure generator in our body to help with feeding and swallowing. Next, we have our hard palate, and that's the bony roof of your mouth. And you need that surface on that bone, on the roof of your mouth to, when you get the nipple in your mouth, to elevate the nipple against it in order to create that pressure that we're going to talk about in a few minutes. And the hard palate is critical for shaping the nipple and creating that pressure in the mouth and helping create suction. And then last, we have the velum. And the velum is our soft palate. And this is what's going to elevate during the feeding, close off the nasal pharynx from the oral pharynx. I learned from Kate Crowley, who is a fantastic cleft specialist at Columbia University. She calls it the top floor and the bottom floor. So that I use that all the time, how the velum is the door that locks off the top floor and the bottom floor. And that's what's really critical when we want to think about nasal regurgitation. When we feed and swallow, it's not comfortable to have things in our nose when we're eating and drinking. So that elevation of the velum is critical to prevent that. And then when we're thinking about a baby's feeding, like a baby's job is to sleep, eat, repeat. Like their job is really, I'm kind of jealous of their job. It's kind of nice, right? But they have to have certain skills in order to be successful and want to do it again and again. So when we think about their physiology of what they have to do, we talked about this where they have to use their lips. Now we know what anatomy is required for that. And the lips, the seal is the foundation for effective feeding when we're using our lips. So this is going to provide the closure around the nipple. It's going to create that anterior seal to create that intraoral pressure. And then we have compression. And compression is going to create positive pressure in the mouth. So it's a positive pressure system. And compression is generated by the rhythmic jaw and tongue movements working together. And the tongue presses against the nipple and the hard palate. And this creates that positive pressure that helps to start stimulating the milk from the nipple, breast or bottle, and help to start hopefully expressing it. When we think about compression, it's compression alone is not efficient enough for milk extraction and milk transfer, but it is important for stimulation of the milk. And then when we think of suction, suction is negative pressure. So we're going to have this positive, negative pressure dance going on. And this is where you create suction. You're going to be using your tongue, your soft palate to create this negative pressure. And this is what's essential for milk transfer. Milk transfer is after you stimulated the nipple, the breast or the bottle, is bringing it from the nipple into the mouth. And that suction is what's critical for the baby to do that over and over again for suck, swallow, breathe coordination. So before we get into what is a cleft, what are clefts that we're looking at in our practice, and how can we work with them with feeding, I want us to really just see the roadmap for the first year of life for a baby and the role of the SLP. And there's a really nice article, I believe it's open access by Dr. Samar and Dr. Wambacher, where they talk about the role of the SLP and how we wear different hats depending on the stage of the life of the baby. So the first thing that we can do as an SLP working with the baby is work with them before they're even born, work with the parents. And this is where we have a role in prenatal counseling, where I'll talk about that at the end of the lecture, so we can kind of see, we can learn about the feeding component, but at the end, see how we can support parents before the baby's even born. And prenatal counseling is typically where we come into the picture around 20 weeks or a little bit older and support the parents with other factors like how to breastfeed if possible, how to bottle feed, how to be prepared for any unexpected events after the baby's born. Now, the second component that we can have a role with the baby and the family is helping with if there's a NICU admission or if there's a readmission into the hospital. Sometimes our babies are not admitted to the NICU right away, but they may be discharged home and they may have a little quick readmission for maybe poor PO feeding or maybe some other issues. So the role of the SLP is really to support feeding development, helps support the plan. Even if you're not in the NICU, help support the plan. Maybe talking to the parents, the nurse, the physicians, and really help support that plan for a safe discharge home, including bottle selection, nipple flow selection, and a pumping regimen, if that's the parent's desire. Typically around 6 to 12 months, and this is very dependent on the team and the surgeon practices, the infant will typically be ready for a cleft palate repair. And the SLP is typically working with the parents before that repair and then after the repair, just to make sure they're doing well with feeding and to make sure they're really adhering to any mouth precautions that the physician team would like the parents to support the baby on. And then at 14 to 18 months, I know it's a little over a little over a year, but this is where the baby has a new palate. Hopefully they're transitioning to, not a new palate, their palate's repaired. And then hopefully they're transitioning to age appropriate solids and learning about food in other ways. But now our job is to really start working on them learning about their palate and working on learning about how to make high pressure oral phonemes. So read that article. I think it's fantastic and it's really nice to see the timeline. So now let's learn a little bit about clefts. And there are many different types of clefts out there, and I'm not going to talk about all the different types. But we know that clefting is a congenital birth defect which can impact the facial structures that typically fuse during the embryonic period of gestation in utero. And because of this, this can impact the lip development or the palate development. And it's one of the most common defects that we can see. So typically like 1 in 500 to 1 in 700 births worldwide. If you look at this picture, it's from an article from Hammond and Dixon in 2022, and it's an illustration of the fetus essentially growing in utero. And you can see when face morphology starts to occur in picture B, you can see that everything is trying to fuse together. And by picture C, you can see there's a bilateral cleft that has occurred, a cleft lip. Versus if you look on the picture of D, E, and F, that's going to be a viewpoint of the palate fusing. And sometimes when the palate has to fuse left to right, for some reason, a cleft palate can occur. And we can go into that in the next slide and talk about it as well. But something to just kind of give us some facts about oral facial clefting is that 70 to 80% are non-syndromic, meaning they're not attached to any syndromes or genetic differences, and that cleft lip plus cleft palate is more common in males than females. But cleft palate alone, meaning it's isolated cleft palate, no cleft lip, is more common in females. Fun facts. And there are different types of clefts. So you can have a cleft lip, which is going to be pictures A, B, and C, and D. And then you can have a cleft palate only. So cleft lip involves the lip without any palatal involvement. It could be unilateral, meaning one side. It could be bilateral, meaning both sides. It could be a complete cleft lip, meaning it goes through the lip and into a little part of the nose, potentially. Or it can be an incomplete cleft lip, where it could just do a little like notch of the lip that is clefted, but it doesn't go completely through the nose. Then we have cleft palate, and that's where it's a cleft palate only, and that would involve the secondary palate without any lip involvement. So typically, if a baby has a cleft lip, you can see that in utero during one of the ultrasound scans, usually around the 20-week ultrasound scan. But most of the time, you're not able to see a cleft palate if there's no cleft lip, unless the baby's mouth is like wide open and you could really see it that way. But most of the time, if the baby has the lip intact, you don't know if the baby has a cleft palate or not. But if the baby has a cleft lip, we're preparing the family that we see the cleft lip, there's a possibility they may have a cleft palate as well. Now, the baby can have a cleft lip and the palate, and that's going to be where it extends from the lip through the alveolar ridge and into the hard palate. And then you can have an atypical cleft. And atypical clefts can be very different depending on the child or the patient. And most clefts are, midline to the face that you see them, but some of them can be lateral, they can be oblique. And those clefts, because they're atypical, are usually attached to some type of genetic difference, but it's not something you see most of the time. The most common that you'll see are cleft lip, cleft palate, and cleft lip and cleft palate. And then when we think about craniofacial differences, not just cleft lip and cleft palate, but we have micrognathia, which is small jaw, retrognathia, which is retracted lower jaw. These are things that can affect when we're having face morphology occurring, could affect how the tongue position is. And if the tongue position is too far back or too far up because of the jaw alignment, that could impact the palate from fusing. We have glossiotosis, which is essentially where the tongue has a back and up tongue carriage. So a posterior to superior tongue carriage. Glossiotosis with retrognathia are common features of puroband sequence. And sometimes this high back position of the tongue can cause the cleft because when it's fusing, the tongue's in the way. We have mid-face hypoplasia. Mid-face hypoplasia you'll see oftentimes in some genetic differences like Apert syndrome, Pfeiffer syndrome, Cruzon syndrome. And there's an underdevelopment of the eye orbits, nose, cheeks, and jaw. And sometimes that impacts breathing. They may have some stertor, which is more turbulent noise, noise coming from the nose. They may have more difficulty with coordinating suck, swallow, breathe. And then you may also have macrostomia, which is large mouth, or microstomia, which is small mouth. So these are things that could impact feeding. It could impact face morphology when that was occurring as well. So when we think about infant feeding, common features or differences. I don't call these disorders because their anatomy is different, so they're going to feed different, right? So we just want to know what these differences would look like so we can identify what's happening with the baby and really talk to the parents about what we're seeing. We know from a Hallmark article from 2007 called The Nature of Feeding in Infants with Unrepaired Cleft Lip and Cleft Palate. They did a study where they looked at 50 infants that were non-syndromic with cleft lip and cleft palate, and they compared them to 20 healthy infants that did not have a cleft. And they looked at different features, and they were able to essentially look at basically biomarkers of the way they fed, and were able to determine specific features that are only seen in children with cleft lip and cleft palate. And that was shorter sucking bursts, faster sucking rates, reduced negative intraoral pressure, which we talked about, right? Where compression is the positive oral pressure and suction is the negative oral pressure. And there's increased compression attempts, meaning the baby latches and then they kind of get off and they try to compress again and they get off, and that impacts the baby. What this should mean to us is what's the clinical significance? Like, why should this matter to us? And there's been some really great articles afterward that have talked about this. Dr. Madhoun, she's one of the lead feeding researchers in the cleft world. She's like, I love anything she writes. It's just significant. It's so great. And this is clinically significant because we know because of their feeding differences, they're going to have longer feeding times. And I know some of us who are feeding therapists, we were like, okay, 25 to 30 minutes is all you got. Because then after that, you're burning energy, you're burning time, you're at risk for losing weight. But this is who they are. They're going to feed longer. So how can we support them if they're going to feed longer? We know that they're going to get tired compared to their peers. So they're going to have increased energy, like poor endurance, right? They're going to just be so fatigued because they're working harder than their peers because they have cleft. So of course they're going to get more tired. Weight gain can be an issue. They're working harder, they're feeding longer, they're doing things that are higher skill basically with a system that is different than their peers. And we know that there's going to be a disruption between the baby and the caregiver. Why does this disruption happen? And this is something that Dr. Madhun talks about in her paper with like maternal distress and things like that, is that, you know, feeding is the one thing that parents want to be able to do for their baby, right? They want to support their baby. They want to make sure their baby feels like they can feed, and they want to be connected that way. And when you can't, and when your baby's struggling because they have differences, not a disorder, difference, and then you start to struggle and you're trying to learn how to be a mom on top of it, there's really this disruption that happens. And many moms will talk about how feeding their baby gives them a lot of stress, anxiety, how they don't even want to think about it because they just get such turmoil from it. So this is a swallow study of a baby with a cleft palate, and it's a very short snippet, and you can see the baby in the front anteriorly has an OG. The baby was still learning to feed, but you can see here that this baby has shorter sucking bursts and a faster sucking rate. And then you can also see, if you watch the baby when they're feeding, they also have some compression reattempts, and then you'll see some nasal regurgitation as well. So you can see they're pumping, they're trying to get the milk out with the adaptive bottle. You can see some nasal regurgitation. They're not getting that good velum elevation. And then you can see that they're trying to suck faster to really get the baby, to get the bolus in. So now that we learned about the anatomy that we need for feeding, we learned about the cleft differences that can occur with feeding and how that's significant for this developing baby. Now I want us to really pause and think about, like, who is this baby who has a cleft lip? What can they do? Because we always want to see about what they can do, because what they can do is going to be their strengths to help me or you as their clinician help support those areas of challenges that we need to help make feeding more successful for everybody. So we know from our anatomy and physiology brain that feeding is going to be difficult if they have a cleft lip because they can't create the seal. But it's not difficult in the sense that it's something that we need to be as concerned about if it was other parts of the anatomy. So if it's only a cleft lip, we know that feeding difficulties only focus on the seal. We know that typically there's minimal feeding interventions that we need to do. Typically we can teach the parent and the baby some techniques, which I'll talk about in a little bit, to support that closure when the baby's feeding. Babies with cleft lip only typically return to birth weight in the typical fashion of 2 weeks, and they're usually around 50% exclusively breastfed. And I met a baby yesterday that had an incomplete cleft lip, and mom and the baby breastfed like a champ. And it was a beautiful thing to see because I was like, this is great. The baby's feeding great. And there was no need for me to do any intervention at all. It was a really great experience to see. Now, if the baby wasn't doing great, and I saw that the baby was having a lot of spillage for some reason, or if the baby was just not able to create that seal with mom's assistance, then I might teach mom some tricks using her fingers to occlude the cleft lip, maybe use some of her breast tissue and help in that sense. If we're using a bottle, the baby can use a traditional bottle. So the baby, depending on the baby's anatomy, if it's only a cleft lip, we might want to use a wide neck bottle. We might want to use a narrow traditional bottle, but the baby doesn't need a specialty bottle. So if the mom wants to use an Advent or a Philips or, you know, any of the cool bottles that are out there now, there's so many, she can, because the baby can create compression and create suction, that positive to negative dance to create milk stimulation and milk transfer. When we think about cleft palate, we want to think about, can this baby breast and bottle feed successfully with a traditional manner? And we know from knowing anatomy, that's going to be more of a challenge. If we're thinking about a baby with a cleft palate and they don't have a cleft lip, then we know seal is not an issue. They can create the seal. So if you're looking at them from the outside, it's going to look like they can make the seal and they can do it pretty well. But if they have a cleft palate, it's going to be difficult. It's going to be more energy taxing for the baby to compress the nipple consistently and to create suction consistently to sustain hydration using a traditional bottle or to breastfeed. Now, in the next slide, I'll talk a little bit about breastfeeding and cleft palate. I'm not saying we can't breastfeed, so I'll talk a little bit about that. But what I want us to really think about is a baby has to eat and repeat at least 8 times a day. And if they're working extra hard when they're using a traditional bottle because they have a cleft palate, then they're not going to be efficient feeders and they're going to get fatigued, and that can impact safety. So we want to think about if we use an adaptive bottle, which I'll go over, that could actually support the baby and they may be very efficient with it and they don't get fatigued and then they don't have any safety issues with it as well. So babies that have cleft palate and are typically slower to return to birth weight, it can typically take up to 21 to 25 days. And we want to really, again, we have to think about using an adaptive feeding intervention or feeding system to help make sure the baby can sustain nutrition, hydration from this component. And when we think about a baby who has a cleft palate, we really want to think about can they breastfeed or not? And I am all about breastfeeding for every baby. But I want us to really think about, can they breastfeed to sustain nutrition, hydration? So if they're cleft lip only, right? Again, like I talked about my client yesterday, cleft lip only, palate's intact, they can breastfeed successfully, exclusively. We don't need to think about anything else, right? They can sustain nutrition, hydration. But if they have a cleft palate, unrepaired, if they have an unrepaired cleft palate and they have a repaired cleft lip, it's going to be difficult to exclusively breastfeed to support nutrition and hydration. Now, that means that we want to think about mom can still put the baby to breast, mom can still be a breast, still feed her baby through the breast, but in different ways. So she can nuzzle with the baby, she can put the baby to breast and then give the baby the bottle, or vice versa. But we want to think globally that this baby has to grow and thrive so they can get their surgery. And if they're working hard to express the milk because it can't generate that pressure and that energy, the pressure because they have the clot, they're going to lose energy really quickly. They're going to get extremely tired and they're going to lose weight. And that's something we have to mitigate from the beginning. So anything that we can do, this is not a breastfeeding talk, and I can do a breastfeeding talk for another day, but I do a whole lecture on breastfeeding with our parents and our and education on that, how we can really support breastfeeding. And it's not something we want to ever give up. There's pumping regimens, there's ways to support your baby, there's different systems that you can use, which we're not talking about today, to still breastfeed your baby. Now, if your baby has a very small cleft, a posterior cleft of the velum, so that means the hard palate's intact, that means everything else is in the anatomy is within normal limits, but just in the back, for some reason, there was a small cleft, the baby may be able to breastfeed successfully. Not always. So it's very guarded. We want to think, we can't say a yes or a no. We want to just monitor the baby. And this is where team care comes up. That's really important, where we think about working with the families, working connected with the doctors, working with the dietitian, making sure that this baby is thriving, but supporting mom's goals as much as possible as well. So just something to keep in mind when we're working with our breastfeeding moms. We talked about this earlier, but this is just to kind of reinforce that our babies that have a cleft lip, have a cleft palate, or both, will have differences when they feed, and there may be some red flags that the physicians are not aware of, and they refer to you as a clinician, or they may, you may see them and you may not be, or your colleague may see them and they may not have a lot of experience with a baby with a cleft palate, and they may think they're aspirating or they're having some difficulties, but these are common differences that they're going to have. So we want to support it and know how to mitigate these differences. So we already talked about compression and suction. So we know that positive to negative relationship. We know that milk stimulation could be, an issue. So if the baby looks like he's feeding from the bottle, but he looks like he's, chomping away, but there's no milk, being stimulated up to the nipple, to the breast or the bottle, and then there's no milk transfer, then we know that the baby is struggling with a traditional bottle. It's normal for the baby to have nasal regurgitation. There are different strategies we can do to mitigate that, and we'll talk about that with the family. But nasal regurgitation, I know it can be alarming to some families. It can be a little triggering. They're like, and it's normal for the baby. But on the flip side, if you're a clinician and the baby, you got consulted for feeding and the baby has no diagnosis and you're seeing overt nasal regurgitation, stop the feeding and look in the baby's mouth. And that happened to my colleague probably like 10 years ago. I remember she was in the NICU and she was like, milk was coming out the nose. And she stopped the feeding, flipped the baby, and looked in his mouth, and he had a cleft palate that nobody knew about. It was a very small cleft palate, but she found it. The baby may have noisy, wet breathing. And then noisy, wet breathing is really going to be something that is from the nasal regurgitation, the milk that's in the nasopharynx. But if it's down here, lower, then that's a little concerning for safety and airway invasion. So we really just want to be able to mitigate what we're hearing. And we are going to talk a little bit about aerophagia. So air intake, babies may get more air in. There's a lot of anecdotal ideas about aerophagia in our babies with clefting. And then we know their feeding volume. Sometimes they may struggle to meet their feeding volume. So how can we support them to meet that feeding volume and their caloric intake? So when we think about intervention approaches, it's always important to really think about 3 different approaches when we are with our babies. So one would be like structural mechanical, the next would be nutritional approaches, intervention approaches, and the next would be neurodevelopmental. So I'm going to go through these systematically. Some of these you may be very, very familiar with if you're in the feeding world, and some of these maybe just you've heard about them or you're still learning about them. So when we think about structural mechanical, that's when we're thinking about the anatomy and we're thinking about how can we mitigate their anatomical difference. And because they have an anatomical difference, we know that flow rate in an adaptive bottle is important for them. Adaptive bottle means it's a specialty type bottle that is made specifically for them, that is for infants with cleft. Flow rate is something, again, another talk for another day that many people would listen to because it's just, it's so many things to learn about flow rate. But we always want to be able to do a feature match with nipples. Not every nipple is the same. And I'm very biased when it comes to nipples. Like, I was like, I like this bottle and I like this nipple. But every baby's different. So we have to really make sure that we're looking at the baby from an oral motor perspective, like what their strength coordination can do related to the nipple. And then think about that sensory component. How sensitive is the baby with the nipple? Some nipples are very soft, some nipples are very pliable, some are harder, and that, what works for that specific baby. And then the baby's age matters. Some of our babies are preemies with clefting, some of our babies are full term, some of our babies have respiratory differences, some of our babies don't. So some of our babies have neurological differences, some of our babies don't. So how is that going to impact the flow rate and their ability to manage the bolus from that flow rate? And then what about their physiologic stability when they're feeding? And then lastly, we always want to think about their safety. So safety, again, is the primary goal for swallowing. And if it's just a cleft lip or a cleft palate, safety should not be a main issue. We shouldn't be concerned for aspiration if we're using the correct strategies to support them. If we're seeing that there's a feeding difference with the baby and we're concerned about safety, that could be something that we need to dig deeper in. And maybe there's another component, another layer to the baby we don't know about yet. And that's what's really causing the airway invasion or airway issue that we're seeing. So I said earlier that, if you have a cleft lip only, you can feed from any traditional bottle typically. And there's so many traditional bottles out there, and they all look different, and they have different shapes and sizes and smells. But for cleft, it's really a very small market. And there used to be another bottle on the market, and they stopped making it, so that's why I didn't have it here. But the way cleft bottles are typically designed is that they're either a squeezable base, which that bottle no longer exists, or has a one-way valve within a system, or that has an internal vent. So I'll kind of talk about some of these bottles here. Full disclosure, I'm on a committee with Dr. Brown's, but that doesn't change the scope of this talk because there's only really 4 bottles on the market for our babies. So if we think about a squeezable base bottle, that means the bottom of the base is squeezed into the baby's mouth. So that way the baby, when the baby sucks, the caregiver is actually squeezing the nipple for the baby, or squeezing the base of the bottle for the baby, so the baby can get the milk in their mouth. That bottle was called the Mead Johnson, and it was stopped production. They don't make it anymore. But some of my moms will tell me that they use other bottles that are commercial, like the Komodomo, which is a very soft, pliable base that you can squeeze. But it's not made for that. So sometimes those bottles, those squeezable bottles that are in the market, they can actually collapse during feeding because they're not made for that. It's not what it's designed for. Then you have a one-way valve system, which is going to be like your Medela special needs feeder. It used to be called the Haberman. And that is going to have a feature in it with a little disc that's going to help the baby create that negative positive pressure in order to stimulate the milk and able to create that milk transfer. It has many pieces and parts, and it works well for many babies. And that one-way valve prevents milk from going back into the bottle and reduces that air intake also for the baby. So the baby is not taking as much air in. The bottle here that you see, that the Medela is going to be the bottle all the way to the right. And the nipple is squeezable for that bottle. So it has 3 lines, a slow flow, a medium flow, and a fast flow. And you take the line that you want for the baby and you direct it more toward the nose, essentially. So you can control flow rate for this type of bottle, but it's a squeezable bottle. So depending how hard you squeeze, depending how the baby's able to generate their own pressure in the mouth with their anatomy, will really depend the bolus size too. Then you have an internal venting system like the Dr. Brown specialty feeder. They have a wide neck and they have the narrow base bottle that you can use as well. And that's going to have a disc system that you can see with the little blue pieces there. So does the Pigeon, which is the bottle next to the Dr. Brown's that has the white collar and the clear base. And essentially with those bottles, the baby just has to tongue pump essentially to create to stimulate the milk, and then they can create milk transfer there. What's good about these bottles, the Pigeon bottle is a bigger nipple, so it can fill up the space of the mouth better. If the baby has a wide cleft, it is a faster flow nipple, so if the baby has a very mature suck coordination and very mature feeding skills, it's a great bottle for them. The Dr. Brown's has a lot of flexibility with their flow rates, and it's very flexible if you need a narrow or wide base, which is nice. And when we think about flow rate and adaptive bottles, we always want to think about the baby's feeding and swallowing skills. So we want to ask ourselves, is the baby efficient? Is the baby safe with this nipple and flow rate? Is the baby able to conserve energy? And when the baby can conserve energy, that means the baby can actually continue to feed and have good stamina. We want to really make sure that the baby is gaining weight with this bottle, that they're successful with it. Middle ear health, a lot of our babies with cleft palate are at high risk for otitis media and fluid in the ears, and they may need tubes later when they have their palate surgery. But there's been some research, not a ton, but there's been some research that talks about selecting the bottle and how that could really If you're using the right bottle, it can really reduce otitis media because you're using a bottle that is matching the baby's physiology and they're not getting fluid on their ears because they're able to redirect the bottle, the milk where it needs to go. And lastly, and this is my most important thing that I always think about, that I'm always like talking about to myself at night when I'm thinking about how to help my babies, is we want to make sure the baby has a good feeding experience because we're teaching the baby to feed for life. We're teaching the baby to learn to trust food, learn to trust their caregiver, and learn to like to eat and so on. So positioning, it's not always just related to the infant's body, but can also be related to the position of the bottle. Dr. Chi Williams, I think she's getting a PhD. I don't know, but she's fantastic. She's another, if you're into cleft and you're into feeding, she's one of the top researchers for cleft feeding, like Dr. Mahoon is. And she investigated in 2026 how bottle angle can influence milk drip rate using the Dr. Brown specialty feeder. And what she found is that using a horizontal like angle of the bottle actually optimize safety and efficiency when using the Dr. Brown's feeder. So essentially the angle, if you're using a horizontal angle for the bottle versus, elevating it, you're actually able to control drip rate. You're able to make sure the baby's not getting too much of a flow, making sure the baby's not leaking everywhere. So it's actually nice for the baby because it's really supporting physiology and it's neuroprotective. But when we also think about positioning, we also want to think about positioning of the body and how that can help the baby with feeding. And there's many positions that we talk about here that we might know if we work with other populations like sideline, feeding a baby upright and feeding the baby prone. Sideline and upright are more common, so I do want to touch a little bit about feeding a baby prone. We're not really feeding them prone, but it's modified prone. Sideline, as we know, is very neuroprotective. It really it's very beneficial for the baby's physiologic stability, and it's going to help the baby really coordinate that bolus hopefully safely and have more prepared time to swallow. And it can actually improve milk flow for the baby as well, like reduce the flow for them and help them become more coordinated. Upright is going to be essentially where we're really supporting them at a 90-degree angle and giving them a lot of neck and trunk support. But modified prone can be used with your babies that essentially have maybe retromicronaphia and can't tolerate sideline or upright because of airway patency. Maybe the tongue falls back, maybe they just can't breathe efficiently when they're in this upright or sideline position. But if you help them go modified prone, just a smidge, you're helping their face going down in an angle, the tongue can drop forward, the jaw can drop forward, so the airway can have more patency, can open up more. And that way, this improves airway patency and the baby can have a nice suck, swallow, breathe when you have them in the modified prone. It's not easy to do. You have to make sure the parents can actually do it consistently, and that can really support the baby. Pacing is a caregiver-driven technique strategy, and this is to aid a disorganized suck, swallow, breathe coordination, just like you would do with your traditional NICU babies or your babies that are having difficulty with feeding. We know that many times pacing can be like a struggle with maybe the medical team because they're saying it takes longer to feed the baby if we're pacing them. But we want the baby to have a safe swallow, so we want to make sure no airway invasion. We want to make sure the baby has a positive sensory experience. And there's been a research in 2025 by Venzura et al., and they showed that pacing did not cause the feeding to be significantly longer than without using pacing. It was essentially the same time. So it just shows that pacing can support the baby's feeding physiology, but also help them become efficient with feeding as well. And then we have frequent burping. And, when I first started Cleft many years ago, I was taught that, babies have a lot of air because they have a cleft, they take in more air and they get belly distension, belly discomfort, and they don't want to eat because of that. And there's really not a lot of evidence to show that. It's just more anecdotal, which is still clinical experience, so it's still validated that it's something that can happen. but we don't have anything to say this really is a thing. But we still want to support the families and the babies. So we're seeing they're taking in a lot of air. If we're seeing they're getting they're not comfortable, then let's pause. Let's give them some burping breaks. And then a lot of times you'll hear these loud burps because they are getting a lot of air trapping. So just following the baby's cues, working with the parents to really support them is really a nice tool to use. Thickening with cleft craniofacial, again, Dr. Chi Williams did a lot of great research on this as well. She recently did a scoping review to really determine about thickening with our babies with cleft and craniofacial differences. And she only found one study that met her inclusion criteria. And it showed that obviously thickening can mitigate aspiration in our population. But thickening is not really it's not really the first step we should be using when we're working with our babies. There's other things we need to start thinking about to mitigate that dysphagia. And I have these different pictures here of different things that we use for thickening because we know that every different institution uses different things to thicken, and thickening can be a whole talk for a whole nother day. But thickening is used for many things besides safety. It's also used to mitigate nasal regurgitation. It could be used to mitigate reflux, but we know that thickening can be difficult to get expressed through the nipple, especially with the discs that are from the adaptive bottles. So I think there is more work to be done on this. There's really no evidence to support it currently from Dr. Shea Williams' paper, but just something to consider. And then lastly, when we think about cleft and craniofacial feeding, we really want to think about nutrition and how we can support these infants that we're working with. And I'm fortunate to work with some fantastic nutritionists, some fantastic dietitians that are very vested in our babies, but we don't always have that in our immediate connection. So how can we work with the medical team? How can we work with the Cleft team to really help support the babies the best way we can? Evidence is clear that early intervention, again, Dr. Williams did a really nice article on the value of early intervention. So working with the baby as early as possible and really supporting that family from the beginning to be proactive, right? To teach the families how to feed their baby. What nipples fit the baby the best? What flow rate works for the baby? Do we need to change position? Do we need to do anything else to support the baby so they can feed safely, feed efficiently, and have a positive experience? Multidisciplinary team care is the goal if possible. And that's really across the board for all feeding babies, not just cleft palate. A feeding log is always recommended, at least for 3 days, to track a 24-hour volume. And that's really looking at feeding times. It's looking at feeding patterns, so we can really see what the baby's doing. Most parents like to use their phone now. But we used to give like a pen and paper log with a folder, and that works for some parents as well. That's how we can really identify a pattern. And then talking with the families about going for weekly weight checks to their pediatrician. Some of our families travel very far to see us, so we can't expect them to come back to us every week. But a weekly weight check is something that's really great, so we can really track weight gain. There are some institutions that actually give their babies with cleft palate, they give the families scales so they can weigh their babies at home as well. And there are some like bassinets that weigh the babies too. But whatever it is, we want it to be something that's consistent. It's always the same one, so we can really track it and really make sure the baby's gaining weight. Fortifying feedings, that's really going to be something that the nutritionist or the dietitian can work on, but we can talk to the dietitian and try to support that. If the baby is a breastfed baby, we know that breast milk is about 20 kcal. So oftentimes the baby may need some fortification with formula, or they may need some things added to the formula to help the baby's weight gain and growth as well. And then if we need to, we might need to increase the calories as well. So increasing calories can be fortifying, increasing calories can be changing the formula to very high calorie formula. There's currently a formula called Fortini, that is, and I'm not endorsing it, I'm just talking about it so we're aware of it. It is a 30 calorie formula. I think it goes from 30 to 45 calorie, and it's doesn't impact the kidneys, because sometimes when you increase calories of formulas, um, depending on the mixture rate and everything, obviously this is not in our scope of practice, this is for a dietitian, but it could impact the kidneys, it could impact the child's system wide, right? But this Fortini formula is a very high calorie formula that doesn't do that. So just something to have in the back of your mind if you're having a baby that's really struggling. So now we're going to kind of just quickly change gears now that we learned about everything that we can do to support a baby, and just briefly talk about prenatal counseling. Prenatal counseling is part of our scope of practice, and on the cleft, when you're working with a family that has a newly diagnosed cleft, it is considered best practice. And it often is, it's usually speech pathology with a nurse. It could be plastic surgery in a nurse. It could be speech pathology in the plastic surgeon. It could be speech pathology in the dietitian. Depends on the makeup of the team. But essentially, you're talking to the families ahead of time, usually after their 20-week ultrasound, and then just talking to them about what can occur for their baby before their baby is born. So this is an evidence-based tool that is currently being researched by a few researchers in the cleft world, including Chelsea Sommer, who's out of here in Florida. But we know that prenatal counseling can reduce stress, can promote parent confidence, can reduce NICU admission because it's teaching the parents the tools ahead of time to know their baby and learn how to feed their baby and know how to use adaptive feeding tools. And we know it can improve quality of life as well. So during prenatal counseling, as a speech pathologist, you're really talking to the families about what they want to learn at that moment, including, do you want to learn about the adaptive bottles? Do you want to learn how to put them together? You need to bring them to the hospital when your baby's born. It is a shared decision making, so helping the families learn that they have a voice when they go to the hospital and they're integrated in their care. We do talk to them about breastfeeding and their breastfeeding wishes and journey, if that's something they're ready to talk about. And then the lived experience is critical. During the prenatal counseling, we offer for them to talk to another family that has a similar diagnosis. We offer them to see pictures of children that have had the same diagnosis and that have a repair and that are thriving. So I'm going to kind of skip a little bit here about barriers for prenatal counseling just for time's sake, but just keep in mind that there's always barriers for anything that we do, and there can be institutional barriers, productivity barriers, etc. But last, I wanted to talk about some training practices. There's a great study by Dr. Kotelek, and she did a really nice study that talked about training and practice patterns, learning about feeding infants with cleft palate. And she identified that there was reduced confidence when feeding babies with cleft palate after graduate school because we don't really get the training. And I didn't get the training. I got on the job training, and I'm still training every day when I still work with babies. I had 2 or 3 yesterday, and I was like, I don't know if I'm aspirating or not, or I don't know if I need to change the bottle. And I've been doing this a long time, and every baby's different. So this is a really great article because it talks about training and practice patterns. And it matters because inconsistent provider training may contribute to delayed feeding. Inconsistent provider training can contribute to poor weight gain, caregiver stress, and ultimately it can impact the surgery. Because if the baby's not gaining weight, then the baby's not going to have their surgery on time. And if the baby doesn't have their palate surgery on time, that can impact speech production later. So our feeding training and practice patterns is critical, and hopefully we can talk about that article on another day because it's just such a great article to read. Here are some great resources as clinicians that you can use and have in your back pocket. American Cleft Palate is the association for cleft and craniofacial surgeons, social workers, psychologists, speech pathology. It's very interprofessional. It's fantastic. The Leaders Project is a great resource to learn about feeding and swallowing with cleft. They have great videos. And then First Droplets is a great resource for breastfeeding. And it truly takes a team. So am only here today because I have a fantastic cleft cranial speech pathology team. To the left is my mentor, Kristen DeLuca, my colleague, Yatela Camargo, and Diana Acevedo, and we're part of the One Cleft team. And then I have collaborators, Dr. Chelsea Sommer and Logan Swain, who have done a lot of collaboration with me on prenatal counseling. So I'm very fortunate that we continue to grow and support our babies and our families. So I want to thank everybody. I'm very honored to be here tonight, and I'm open to any questions.
Awesome. Thank you. The presentation was amazing, and we do have a few questions. So we will dive into those. Quick housekeeping. If you'd like ASHA CEUs for this presentation, the link to the survey is in the chat, and then the email to send a request for a certificate of completion is also in the chat, and this will all be sent out again via email from Zoom. So let's jump into some questions. This attendee said, do you find a common occurrence of upper lip tie with unilateral incomplete cleft lip?
A great question. So if it's an incomplete cleft lip, then I think we have to really, it depends on the position of the, if it's unilateral, left or right, and then where we're suspecting the lip tie. I will say I typically don't see lip ties when it's a cleft lip. The anatomy may be different, so I think looking at the child holistically and looking at the alignment of the maxilla and the mandible, looking at the alignment of the skull base angle, and then really making that determination. But if we're concerned for any tethered oral tissue, I always consult with my otolaryngology colleagues as well as my plastic surgeon because they're the one doing the surgery. There is something that the surgeons do to try to approximate the lips. They could do lip taping, they can use nasoalveolar molding, and there's other types of like obturators they can use to bring the lips together. So we would want to really wait till they repair the lip typically to see if we see any atypical oral tethered oral tissue, but it could happen. I just haven't really seen it.
This person said, is it possible for a baby with cleft to not be able to feed with a specialty Dr. Brown's bottle?
Right. So the adaptive bottles, if it's isolated cleft, it doesn't have to be Dr. Brown's. It could be the specialty needs feeder. It could be the pigeon feeder. They should be successful. If the baby is struggling with the adaptive bottles and they have a cleft palate, cleft lip, then we need to just really do our normal feeding assessment and see what's really happening with the baby's tone, the baby's overall like coordination when they're feeding and what's really happening. Oftentimes our babies may have some cardiac differences that nobody's aware of yet. So we want to make sure it's not an energy expenditure challenge because of the cardiac issues. It could be something more. So just thinking of it like that. But when in doubt, if you're not part of a craniofacial team, call your craniofacial team and ask to do a collaborative assessment together.
We had a couple of questions specifically about counseling. Several attendees wanted to know what code you're billing for prenatal counseling as a speech pathologist.
Yeah, great question. That was going to be one of the barriers that we talked about. Most institutions, if you're not under like a physician, like if you're not part of plastics and you're like if you're part of plastic surgery, which my institution we're not, but if you're part of plastic surgery, some institutions you can do a code that's the physician code. So you don't have to worry about you billing for productivity purposes. But most institutions, it's speech does not have a billable code. Now, in the past, people have asked us about what about the caregiver code that's out now with ASHA? Unfortunately, the baby has to be alive for that code. Like the baby has to be here. So that code does not work. So that's where the barrier with productivity standards comes in, which I didn't talk about for time's sake, and institution understanding of the value of prenatal counseling. Because prenatal counseling honestly doesn't just have to be for cleft. It could be for cardiac. It could be for encaphalocele. It could be for like so many things. Congenital diaphragmatic hernia. I mean, it could be for so many things.
I know we're over time, so I want to be respectful of your time and everyone on the call time, but I do want to mention that an attendee said that it wasn't a question, but thank you for the presentation because her son was born with a cleft lip, and this topic is near to her heart. So thank you for providing your expertise. And I know we didn't get to all of the questions. We got to most of them though. So if you do have a follow-up question that we missed, feel free to send us an email at tims-tims.com. And I know there are some questions about if this will be recorded and if the slides will be available. Dr. Garcia was gracious enough to provide us with a handout, so that will be up on the website with the replay within 24 to 48 hours. But like I said, if you have questions, just send us an email at tims-tims.com. And I want to thank you all for being with us this evening. We really appreciate it.
Thank you, everyone. Connect
Bye, everybody.
later. Bye-bye.